Perfect. All right, so let's go ahead and share my screen and we will bring that up. Okay, there we go. I don't know that that is what I wanted. So this is, sorry, it's almost like I have not shared a screen ever before. So there we go. Okay. So welcome everyone to the August version of the JVS Online Journal Club. We're thrilled to have everyone here, and we're excited to welcome our guests, both our faculty and trainee guests, as well as our moderators. Today we have two great papers that we're going to be discussing, which is the paper from Dr. Pasquarelli and Dr. Kim, who's here, Current Outcomes Following Upper and Lower Extremity Arterial Trauma from the National Trauma Data Bank. And then Dr. Brook is joining us from vacation, and his trainee, Taryn Holman, who is a third-year medical student, will be talking about long-term patient-reported outcomes among patients undergoing revascularization versus medical therapy for intermittent claudication. Our host institutions today, University of Michigan and New York University. That's the new spelling that we're using if you didn't catch that. So University of Michigan, from University of Michigan, we have Dr. Robert Below, who is an assistant professor of surgery, and then Dr. Drew Brait, who is a fifth-year integrated resident. From NYU, we have Dr. Sadek and Dr. Wachuka, who are going to be going over and giving us some education on their article as well. As
Dr.
always,
Humphreys, you're in like note view.
Oh, yeah, that would be lovely.
It.
Okay,
Yeah,
sure.
sorry. Thank you. That's better.
Wonderful. Okay. It's hard for me to know which side comes on. So thank you for letting me know. From the first article, we have Dr. Kim. She is here. She is a vascular surgeon in Bellevue, Washington. And Luigi Pasquarelli, who is a professor of surgery and the associate chair of diversity, equity, and inclusion at the UNC. We also have three guests from the University of Utah. As I mentioned, Dr. Ben Brook, who is the associate professor of surgery, chief of the division of vascular surgery. Taryn Holman, who is a MD PhD candidate and third-year medical student. And then Callie Johnson, who's an assistant professor and co-director of the aortic program. We normally have two moderators, which are our special guests. Dr. Kroll is here. She is a vascular surgeon out of St. Anthony's Medical Center at Rockford, Illinois. And unfortunately, we've had a last minute kind of emergency. So we're going to just adjust our moderator, and I'll help moderate the other article. We do like to go over just a few housekeeping things. So we ask that you stay muted. We can have you put your questions and comments in the chat, and the moderators may call on you to speak. The event is being recorded for on-demand access. And then, of course, we are in August, but in September, we will have, on September 11th, we will have the September JVS Online Journal Club hosted by the University of Rochester and LSU. And the link for registration for that is on the website. But of course, we'll also send it out for the program directors. So I will stop sharing my screen now. And I think if we want to get started, we can go forward. Dr. Sadek, do you want to start?
Sure, absolutely. Let me share my screen. Broadcast. All right, can you see my slides fairly well?
We can. Perfect.
Perfect. So thank you for the opportunity for NYU to present the August JVS Journal Online Club. I'm Mike Sadek, one of the vascular surgeons at NYU, and our R5 vascular integrated resident, Dr. Chuma Wachuku, will be presenting the article. So just as a brief introduction, there are no relevant disclosures. We'll be discussing this terrific article from the recent Journal of Vascular Surgery put out by the University of North Carolina group, and it was also presented at the Southern Association for Vascular Surgery meeting in beautiful Rio Grande, Puerto Rico. Dr. Kim will be presenting, and Dr. Pasquarello is the senior author. So just as a brief background, in the modern era of trauma, the management has evolved. There have been increased penetrating and firearm-related injuries. This was put out by recent data from Morbidity and Mortality Weekly Report from 2022, and this has been associated with significant logistics as well as a financial burden. In terms of the morbidity and mortality in the long term, we know that explosives are worse than firearms, which are worse than non-firearms, which is relatively straightforward and intuitive, but the Kaplan-Meier curves are rather startling when you do look at them. And we also know that the long-term consequences of lower extremity amputations are quite significant in terms of phantom pain, barriers to independence, occupational impairment, etc. So what are the risks of amputation? The last time this was looked at was from the National Trauma Data Bank from 2012 to 2015. And we know that the mortality runs around 2 to 3% for both upper and lower extremity trauma, but amputation rates are much higher for lower extremity trauma as compared to upper extremity. And to sort out why that's the case, there was a recent meta-analysis and systematic review, and it's a little unclear. Every study shows that, you know, one factor such as mechanism of injury may be associated, however, it may not be associated. So when you put things together, it's a little bit unclear, and hopefully today's article will shed some light on that. And lastly, you know, one of the things that it has been looked at is PTFE versus vein bypass. And it seems that PTFE may be worse, but again, in larger reviews and meta-analyses, this has not been borne out, only in single center series, such as this one, the Annals of Vascular Disease. So thank you again for the opportunity. I'll give it up to Dr. Wachuku and the UNC team, led again by the lead author, Dr. Kim, who will update us on the latest regarding upper and lower extremity arterial trauma. And I will stop sharing my screen right now. All right, perfect.
Okay, now thank you for that introduction, Dr. Static. I will start sharing my screen. Just one moment. Okay, so again, okay, yeah, just making sure I'm unmuted. But thank you everyone for this opportunity to present this excellent article. The title, as described by Dr. Static, is Current Outcomes Following Upper and Lower Extremity Arterial Trauma. This was using the National Trauma Data Bank, recently published in JVS. So Dr. Static did an excellent overview of the background and some of the prior studies looking at this topic. So while presenting this paper, I want to first dive into the methodology that was used. So the study design relied on using the National Trauma Data Bank research data set. So it's the largest repository of de-identified trauma patients in the United States, and includes variables such as demographics, vital signs, diagnoses, procedures, and like many of these multi-center databases, participating centers are allowed to use the database for quality and research purposes. So this ended up being a retrospective analysis from 2016 to 2020, and diagnoses and procedures were used in the 10th, or provided from the ICD 10th edition. So participants that were included in the trial were patients that were admitted to a trauma facility with any arterial injury involving the artery's name. So the axillary, brachial, ulnar, radial, femoral, popliteal, tibial, or perineal arteries. Patients without arterial injuries were excluded, and then only patients who had open surgical interventions. So naturally, that means endovascular revascularization was excluded. And then patients who were not admitted to the hospital from the emergency departments. So that means that they were either sent home, they expired, they left against medical advice, or they were transferred to another hospital. Some of the variables that were collected were actually demographic variables related to age, gender, mechanism of injury, and then some of the pre-existing medical comorbidities, and then some of the clinical variables relevant to the traumatic incident were naturally collected, including vital signs recorded upon arrival, their abbreviated injury score with severity, then various diagnoses and procedures that performed upon that admission. The procedure types were delineated into either a primary repair, an interposition repair, or bypass. And then bypasses were further stratified into the conduit used, whether or not it was venous, arterial, it was synthetic, xenograft, and then homografts were also delineated. The primary outcome of the study was in-hospital mortality, and then secondary outcomes were length of stay, major amputation, and unexpected return to the operating room. In terms of statistical analyses, use a modified Charlson Comorbidity Index. And then in terms of statistical significance, they defined that at a p-value less than 0.05. They compared continuous variables among groups using a one-way ANOVA with means and standard deviations for normally distributed variables. And then for non-normally distributed variables, they used the Kruskal-Wallis with medians and interquartile ranges. Proportions were compared using chi-squared analysis, and Poisson regression models were constructed to assess incidence risk ratios of mortality, amputation, and unexpected return to the OR. All of this analysis was performed within STATA, and the study was exempt from the Institutional Review Board at the UNC Chapel Hill. Here's just a supplementary table that was published in the online version of this article, just to outline some of the comorbidities that are included in the Modified Charlson Comorbidity Index, just to get a sense of the wide range of comorbidities ranging from cardiac comorbidities, from MI and congestive heart failure, to pathologies such as connective tissue disease, different kinds of malignancies. There's an age stratification. So it's pretty wide reaching. So now it's going into the results. So just some of the high level calls from table 1 before we take a look at it. There was a total of 8,780 patients that were found with a slight predominance for upper extremity injuries. It's 5,054, which is about 58% of the cohort. And then 3,726 of the patients had lower extremity injuries. The overwhelming majority of the patients were men. That was about 83%. And then the mean age was about 34 years. Penetrating mechanism was the predominant mode of injury in both upper and lower extremity trauma. And then they had a mean injury severity score of 14 with a standard deviation of 8. And then among revascularization method groups, there were some variables that were statistically significantly different between the groups. And one is that the injury severity score was higher in patients with synthetic bypass. Then continued into table 1, the majority of upper extremity injuries were able to undergo primary repair. That was about 67%. Then naturally, the remainder received a bypass or an interposition graft. Whereas lower extremity vascular injuries were more likely to undergo bypass. So that was approximately 52% of these patients. And then smaller proportions underwent primary repair, about 34%, and then 14% underwent an interposition graft. So here's just table 1 is very large and contains a lot of information. So I broke it out into a few slides. So the high-level callouts that I discussed earlier were the main things I wanted to discuss, but a few other things that I noticed were that in terms of disposition from the emergency department, the overwhelming majority of these patients went to the operating room straight away, which would make sense that if you have an identified arterial injury, that's usually the most appropriate, sounds another extenuating circumstance. So that was true for this is just the upper extremity injuries where you see that. Going further, here's lower extremity injuries, and you see that same. And on the second side, you see that same predominance towards the operating room disposition. looking now at table 2, this was when we stratified risk of amputation based on location of injury. So what was interesting is that axillary or brachial artery injuries result in amputation 4 to 6% of the time. And whereas radial and ulnar injuries result in amputation very rarely, which would seem to make sense. A more proximal injury would portend a higher risk of amputation. However, what was interesting here is that they noted that distal injuries in the lower extremity result in a higher incidence of amputation. So these popliteal and tibio-peroneal injuries were more likely, they had amputation rates of 19% and 10 to 14% respectively, where femoral injuries only had an amputation rate of 6%. And then multiple arterial injuries resulted in a higher incidence of both upper and lower extremity amputations. Then looking at that in table 2, what's actually interesting about that is that if you look at the greater than 2 leg artery injuries line, that actually is that actually had a higher amputation, that the popliteal and tibial injuries had higher amputation rates than multiple leg arteries injured at once. So that was interesting to see, and I would not necessarily have expected. Oh, apologies. Moving on to table 3. This is when they stratify the risk of amputation based on conduit that was used. And echoing the prior data that Dr. Sadek touched on, use of a prosthetic conduit was associated with a 6.7-fold increase in the risk of amputation for the upper extremity, whereas the vein bypass was associated with a 2.4-fold increase. Then as for the lower extremity, that same use of prosthetic conduit was associated with a 2.4-fold increase in amputation risk. So still an increase, but significantly less than the upper extremity. And then for a vein bypass, there was a 1.9-fold increase in amputation rate. And apologies, just to clarify, this is all compared to primary repair. So this is all the risk of amputation relative to primary repair for both upper and lower extremity injuries. And then when looking at sex, it was not really necessarily associated with an increase in arm amputation rates, unexpected return to the OR, or mortality. But female sex was associated with slightly lower leg amputation rates. What was interesting, though, is that because female patients constitute less than 20% of the cohort, that might slightly confound some of the numbers that we're seeing, just because the proportions were significantly lower. And then here's table 3, just to visually represent some of the numbers I just discussed. So as we see that, we have primary repair set at 1, and then when looking at interposition grafting or using a synthetic bypass, when looking at a vein bypass or a synthetic bypass, there's a significant increase in amputation rate for the upper extremity, and then for lower extremity as well, even though the numbers are markedly lower. Just to synthesize some of the findings from the tables 4 and 5, there was looking at some of the factors, whether or not which conduits were associated with either unplanned returns to the OR or mortality. In general, interposition grafts and bypasses, when compared to primary repairs, were associated with increased unplanned returns to the OR, and similar to amputation rates, synthetic bypasses fared worse than vein bypasses. This was for prosthetic bypasses, it was a nearly 3-fold increase in return to the OR for the upper extremity, and a 2.4-fold increase for lower extremity bypasses. Vein bypasses were associated with 1.8-fold increase in the return to the OR for the upper extremity, and 1.6-fold increase for lower extremity. So pretty comparable there. And lower extremity injuries were more likely to result in amputation and death than upper extremity injuries. So seem to be significantly more morbid. And a penetrating mechanism was associated with nearly 2-fold increase in mortality. But however, a penetrating mechanism was protective against amputation. So here's table 4, just outlining some of the data that we just discussed. And looking at those unplanned returns to the OR, it was significantly more common with vein and synthetic bypasses for both upper and lower extremity injuries. And same with table 5, looking at risks of mortality, just to outline some of those numbers. So moving forward into the discussion. So in terms of upper and lower extremity injuries, so patients with lower extremity injuries more often faced amputation mortality. And this was echoed by prior reports. There was one by Tan et al. In 2011 that found lower extremity injuries to be more morbid and have a lower survival rate. And then there's that interesting split in which we see proximal vascular injuries in the arms causing, or more proximal vascular injuries in the arms are more likely to lead to amputation, where more distal injuries in the lower extremities were more likely to lead to amputation. The lower extremity injury cohort did have a more severe injury burden. So the injury severity score in the lower extremities was 16.6, and it was opposed to 12.7 in the upper extremities. And the hospital length of stay was much longer in the lower extremity injuries, 11 days versus 4 days. And they also concluded that there was likely a greater extent of injury, given that a greater number of lower extremity injuries required bypass rather than primary repair. So it just, in general, it seemed to be a more challenging cohort and set of patients to be treated. In terms of trends over time, the proportion of the age and gender of trauma patients did not really seem to differ from prior reports. However, the proportion of penetrating mechanisms seemed to grow substantially. So in this cohort, it was 67% in lower extremity trauma and 73% in upper extremity trauma, whereas compared to a 2011 report, it was 44% and 33% respectively. So it was a pretty substantial increase. Then the mean injury severity score increased from about 11 to 14. However, the limb salvage rates and survival rates remained high. This study echoed prior reports that prosthetic use is associated with increased unplanned returns to the OR and increased limb loss. And in terms of just the numbers, just reproducing some that were already discussed earlier in the presentation, that 6.7-fold increase the 6.7-fold increase in amputation rate for upper extremity bypasses and 2.4-fold increase of amputation for lower extremity is quite dramatic. And then that's consistent with there was a systematic review performed between 1982 and 2008, which demonstrated an 18 times risk of major amputation when using prosthetic bypasses in a trauma setting. So naturally, any retrospective study, with any study, there are numerous limitations. This is a retrospective review, so that just may limit the variables that were able to be collected. There's lack of granularity associated with large database studies. So while we were able to, there was significant detail as to the anatomy as to where the injuries occurred. We do not know whether or not these injuries appeared to be transections, whether or not they were causing pseudoaneurysms, whether or not it was whether or not these were in the setting of pure intimal disruptions. So these injuries can present differently and look differently. We didn't have that information. The authors mentioned some of the social and non-clinical factors that affect the ways that patients present to the hospital and are treated during their hospital stay and subsequently that can't be collected. And then there was, while we have the injury severity score, we didn't necessarily have tons of information about concomitant injuries. Injury severity scores have been criticized for a lack of internal consistency. There might be a patient might receive a certain score for a head injury versus an abdominal injury, but they might have two completely different clinical implications. Then this is a multi-center database. So naturally treatment capabilities and preferences may differ by center. So there are certain injuries that might be treated endovascularly at one center and therefore be excluded from the study, but might be treated open in another center and then included. And overall, despite the pretty dramatic findings of synthetic bypasses, it was only 1% of the upper extremity injuries and only 8% of the lower extremity injuries. So therefore, and similarly with homograft and xenograft conduits, it was a very low proportion. So just analyzing and extrapolating that data, generalizing that data is a bit difficult. And then while we have great descriptions of how the patients were able to do in that first hospitalization in those initial 30 days, there is a lack of long-term graft patency data to extrapolate from. So some conclusions. In recent years, the majority of vascular extremity trauma is now due to penetrating injury. However, limb salvage rates and survival rates are remaining high. Lower extremity injuries are more often leading to amputation and mortality than upper extremity injuries. And the most frequently used bypass conduit is vein, which is associated with a lower risk of unplanned return to the OR and limb loss. Thank you, everyone, for your time and for this opportunity to present. I'm happy to take any questions and happy to discuss the article further.
Thank you very much. The good news is if you present all of it, we don't necessarily make you do all the questions. We're going to make Dr. Kim do all the questions, or the baby, because the baby is here too, we were told. So I'll start, Dr. Kim, with a question that Dr. Forbes posed. And he basically said that not all penetrating injuries are equal. And was there a comparison between, say, lacerations due to knives versus ballistics? And could a difference in the type of penetrating trauma between upper and lower extremities account for some of the differences that you see in this study? And you have to unmute yourself.
Oh, I'm sorry. Thank you. Always forget to do that. Yeah, that's a great question. And obviously, this is one of the downsides of such large databases, because they don't really get into these granular data in terms of really specifying what kind of stab injury or gunshot wounds versus, or motor vehicle accidents versus motor versus person. So that type of granularity is not really that clear on these databases for such articles, unfortunately. So I don't think we can really answer that question from these data sets. And I guess along the same vein, I think Dr. Abai also asked whether there was a discussion of temporary shunting in these situations. Again, it's really hard to get that kind of granular data from this kind of data set, because they don't really collect whether the temporary shunting was used prior to transfer. Because when the patients were entered into the data set, they only enter it at the time of the recipient hospital, if the hospital is a participating hospital to the NTDB data set. So, those sort of, that kind of sort of information gets lost, and we don't have the capacity to really get into granular data to really kind of find out how we can better understand and interpret the data, unfortunately. But I think it's kind of the point of doing this kind of large scale data analyses is to get a overall view of how the trends have occurred and how things are different compared to our historical data, and to get the general sense of how we're treating these patients on a national level, so that we can get into answering these granular questions in subsequent studies.
Dr. Forbes also had another question just about excluding the endovascular repair. And do you think that that really impacts our understanding of the strategies that maybe are being used more frequently to treat these patients?
Yeah, and that's a really great question. And we actually wanted to target endovascular repairs too in this study, because, really current outcomes in the era of endovascular treatment, we should really be able to address that issue. And NTDB actually started enrolling and specifying whether the patients were treated with endovascular repairs, but it was more recent, and we didn't have enough really data to answer our questions to be in a meaningful way. So we ended up deciding to exclude a few that they entered into the data set.
And I think that kind of goes on with the last comment here, especially where subclavian injuries are treated with the endovascular therapies. I'll ask a controversial topic because that's the way I roll, but Can you tell if there were trauma surgeons or vascular surgeons that treated these patients within the database? Because that stirred up a lot of controversy over the last couple of years.
Sure. Actually, no, they do not specify what type of surgeons were treating the patient. And if you think about it, these NTDB dataset participating hospitals include not only the coronary and tertiary referral centers, but also these private sectors or community hospitals that may not be level 1 trauma centers. So it's foreseeable that a lot of these patients were initially treated by general surgeons or trauma surgeons. And subclavian artery, yeah, and also the subclavian artery, just wanted to say, we did not include subclavian artery into the data set. We wanted to do more limb specific, because by the time you get into the great vessel, it gets muddy. So we only included up to the axillary artery.
And then just to finish this off with one more question, can you tell anything about anticoagulation? I know that in the past, when we've done some work with this database, there was some data maybe about antiplatelet or anticoagulation. We're able to look at that and see if there was any kind of difference. You got to unmute it one more time. I know it's a little tough.
Sorry about that. No, we did not include anticoagulation method because I think that was too granular for the data set.
All right, well, thank you very much. Really kind of some insightful work. Trauma, I like trauma. I'm an O and or a 5 and 2. And so doing general surgery, it was one of the things I loved the most. So it's still one of my most favorite things to be woken up at 3 o'clock in the morning for. So
that's wonderful.
We're gonna transition over to our next paper. Dr. Below, do you want to go ahead and get us started?
Yeah, certainly. And I think Drew's going to share our screen here, so I'll make sure it comes up. Awesome.
Lovely.
Well, so my name's Robert Beaulieu. I'm one of the vascular surgeons here at the University of Michigan, the national champions, for those that follow that. And then we have Drew Brait, who is one of our integrated vascular surgery residents as well. And we're really excited to be able to bring you a paper, or just the discussion of a paper, Drew, next slide, regarding the long-term patient-reported outcomes among patients undergoing revascularization versus medical therapy for intermittent claudication. And we feel also really fortunate to have Taryn on the call here, who seems to have benefited from the mentorship of Drs. Johnson and Brooke. And Ben was my chief resident when I was an intern. So it's really come full circle. I get to now scrutinize his work. Go ahead and click on the first one. The availability of minimally invasive endovascular techniques for managing intermittent claudication has fueled a significant increase in lower extremity interventions, which have basically tripled from the late 1990s to the mid 2000s. And this rate seems to continue to grow, as you can see echoed here in this graphic. Now, this has happened despite interventions for other indications such as ulcers, rest pain, and gangrene, sort of the classic CLTI ones that are no-brainers for interventions, remaining pretty much stable. This trend should be seen as potentially concerning for a number of reasons, including evidence showing higher rates of progression to CLTI and to amputation among patients with intermittent claudication that undergo intervention. And I think, this is obvious to everyone on the call, but this trend has the further potential to really erode the national trust in our specialty, with reports of misuse of lower extremity interventions jumping from beyond the medical journals to the New York Times, and certainly fueling many questions that will come into us in our clinics. So to help address these concerns, the SVS published appropriate use criteria in patients with intermittent claudication in 2022. These guidelines state that invasive procedures should be reserved for patients with intermittent claudication that's lifestyle limiting symptoms, and only after there's been an inadequate response to medical management and exercise therapy. And while helping to restore the principle of beneficence among vascular surgeons, these guidelines can still leave a little bit of room for controversy in the clinical decision-making for patients with intermittent claudication. There are questions about what adherence to medical therapy actually means. For instance, if you have a patient who loses their job because of an inability to walk, but they can't quit smoking, are they adherent to medical therapy or are they non-adherent to medical therapy, and should they be offered an intervention? And further, who really gets to define an adequate response? And this is really the focus of this article, because to date it has largely been this who gets to define has largely been driven by objective measures like improvements in your ABI or increase in pain-free walking distance. And these can really be measured pretty much independent of the patient's perception of their own health or their own response to therapy. So it's kind of cool to see that in 2024, the European SVS guidelines published clinical practice guidelines for intermittent convocation that included looking at quality of life outcomes as they pertain to interventions on intermittent claudications to now start the conversation of how these should aid in our decision-making processes for patients. Next slide, perfect. So really these patient-reported outcomes in intermittent claudications, just to give some context for what those are, these are standardized and validated questionnaires of a patient's self-reported health. They don't require interpretation of a provider, so you or another member of your clinic. These have sort of gone to the forefront as important documents as the Centers for Medicare and Medicaid Services, or CMS, has identified these PROs as a priority outcome for measuring the quality of care. So it goes beyond these objective measures that we would typically be judged on for our performance, and now really brings it home that the patient's perception of their experience is an important outcome that's validated at the highest level. Despite such broad support for these, there's really been few studies to sort of determine the different effective treatments that we have for lower extremity claudication, but most vascular surgery procedures, to be honest, and patient-reported outcomes. And it's encouraging to see things like PCORI become a funding mechanism that's so highly utilized by vascular surgeons, as this puts patient-centered outcomes at the front. But there's still a lot of work to do in bringing these as a regularly used metric that us as vascular surgeons incorporate into who we treat. You can see a example questionnaires there and the domains and the method of which you can see that most of these are Likert scales. Again, that allows the patient to fill these out on a continuum and can allow for a little bit more granular data. And go to the next slide. So two of the bigger RCTs evaluating endovascular therapy in patients with intermittent claudication have included some element of PROs as secondary outcomes. So here you can see the CLEVER trial, and there's an improvement in two measures of physical quality of life scores in patients with intermittent claudication undergoing stenting compared to medical therapy or supervised exercise therapy at 6 months. And this is despite data from the same trial showing similar objective measures between the two groups at 18 months. So together, these suggest that perhaps PROs, these patient-reported outcomes, help paint a more complete picture of how a patient perceives their therapy that may be independent of the measures that we've previously been exploring, sort of gives fuel to the fire for a study like what has been published by this group. This potential discrepancy between objective measures like ABI and walking distance with PROs was shown again, some would even say mimicked, in this additional trial here. Here it is seen despite an improvement in objective measures at short-term follow-up, there was really no durable impact on the quality of life for these patients. So that sort of flipped the script a little bit. You know, the previous study, the CLEVER trial, showed some 6-month improvement in patients' PROs, but similar objective measures amongst the two treatment strategies, not just medical therapy, but supervised exercise therapy. And here we're seeing they actually have differences in their objective measures, but their PROs are the same. And so I think these two things together really paint the picture that there needs to be a better understanding, and you can go to the next slide, Drew. There needs to be a better understanding of the roles and how PROs can factor into the management of patients and what their importance is, and honestly how we tie those to some of the outcomes that we may have seen before. So with that, I'm going to turn it over to Drew to walk through the specifics of this really interesting paper, hopefully with the context that now gets you really interested in these PROs and outcomes in intermittent claudication.
Great, thanks. Hopefully everyone can hear me okay. Appreciate the opportunity to present to you all, and this is a really great paper. I enjoyed reading it, and look forward to the discussion. So this was a retrospective study, single center. So it was retrospective identification of patients with PAD that was identified through ICD codes, and this was over a 5-year period. Patients were obviously excluded if they had not completed at least one PRO assessment. Chart review was used to confirm that they actually did have intermittent claudication, and patients who were deemed to have CLTI were excluded from the study. All patients were followed for a minimum of 1.5 years, and they used CPT codes to identify interventions that were then stratified by the intervention type. The non-operative patients obviously did not have a revascularization. They were placed on optimal medical therapy and then a recommendation for supervised exercise therapy. Follow-up was at 1, 3, 6, and 12 months, and then annual after that for the surgical arm. So this is just a little breakdown flowchart of the kind of inclusion exclusion criteria. You can see that they originally started with a little over 800 patients. Looks like a majority of patients were excluded for CLTI, 152. That then left them with 225 patients for inclusion, of which 136 went non-operative management, 89 went revascularization, and the majority of those were endovascular, but there was a subset, 37, that had open bypass. So when we look at the PROs that were used in this study, it's different than the ones that Dr. Boyu had introduced. So they use this patient-reported outcome measurement information system, or PROMIS, which is a great name, I have to admit. And this is split up into 2 different kind of components. There's a physical function component, which rates the difficulty in performing everyday activities that require physical movement. And then what's really cool about this is there's also a satisfaction in life, satisfaction in social roles and activities component. And this is where the patients can rate their engagement and general happiness in their social relationships. So these are voluntary. They're completed before the appointments with the vascular surgeons. And this PROMIS kind of worksheet was developed actually by the NIH. And it's meant to mimic a standard curve. So it ranges from 1 to 100 with a mean of 50 and standard deviations of 10, which is really nice. And a higher score is a higher function, so a higher physical function or higher satisfaction. They also collected a handful of other variables, demographics, comorbidities, laboratory measurements were included if they were in 3 months of their appointment, and then ABIs with segmental pressures. Statistical analyses in this were for t-tests and chi-squared for variables with normal distributions, Mann-Whitney U-tests for those with non-normal distributions. They used Kaplan-Meier curves for mortality and log-rank tests for overall survival. And then they utilized a linear mixed effects model to examine the correlation of these different treatment modalities on each individual patient's PRO score and ABI over time, which was really interesting. So this is table 1 is kind of the baseline characteristics of these patients. Of note, a majority, or the average age is about 66. That's kind of what we'd expect. About 40, a little less than 40% were female. Majority were Caucasian, 94%. When comparing kind of general demographics between the patients who had revascularization and non-operative management, the patients who had revascularization actually had higher frail scores, or more likely were deemed to be frail, which is a little bit interesting as well. This is a continuation of table 1, like Chuma had in the first one, is a big table, so I split it up. So looking at some more kind of comorbidities as well, really the only thing that was different between the 2 cohorts or arms was the prevalence of cerebrovascular disease, which was actually higher in the patients who had non-operative management. And then very interesting, ABI was higher in the non-operative management group, not too surprising there, as the patients with revas probably had lower non-invasive studies. Just finishing off the characteristics, this is the PROMIS scores, so the 2 different ones, the physical function and then a satisfaction score. And you can see that while there was just a trend for a lower satisfaction score for those undergoing revascularization, it was statistically significantly lower for physical function, which I think makes sense when you think about that. So figure 2 is a Kaplan-Meier curve looking at overall survival. You can see the medical management arm in the dotted line and the revascularization arm in the solid line. 21% of medical patients and 17% of revascularization patients died from any cause during the study, but there was no overall difference in their survival. And you can see the hazard ratio and confidence intervals there. Figure 3 is looking at the difference in the patient-reported outcome measures. So on the left, in A is the physical function, and in B on the right is the satisfaction and activity score. And you can see that the revascularization cohort had a lower absolute physical function at baseline, but this increased after surgery, and that increase sustained over time. However, there was still no difference between the medical management and revascularization arms. And when you look at the satisfaction scores, the non-operative patients are more likely to have improvement in their satisfaction scores over time than the revascularization patients. Figure 4 is looking at ABIs and the trends over time between the medical management and the revascularization patients. You can see that in figure 4, the revascularization patients had lower ABIs at baseline, like we talked about, but those did increase after surgery, and that increase again sustained over time. And when you look at 5 years out all the way to the right on that graph, the revascularization patients still had higher ABIs than the medical patients. And actually 30% of patients who had revascularization had a low ABI, and then that improved to a normal range after revascularization. Figure 5 is looking at the physical function, and they've broken it up really nicely into patients who had ABI improvement and no ABI improvement. So obviously this is patients who had revascularization. And there was a significant difference at 180 days, so an early improvement in ABI. Or in physical function if you had an improved ABI, but there was no difference in the overall trend. And then figure 6 is looking at stratifying patients on the type of intervention that they received. So these are all patients who had intervention, and you can see they've broken up into peripheral vascular interventions and open bypass. So there's no difference in physical function between procedure types, and there was also no difference in ABI. And 1-year reintervention rates in the revascular patients was 30%, and patients with the bypass actually had higher rates of reintervention compared to the endovascular patients, which I found actually quite surprising. So when thinking about kind of the discussion and the main points of this, it really boils down to traditional objective measures that we use when looking at patients and managing patients: vessel patency, ABI, walking distance. Like Dr. Beaulieu kind of introduced for us, those really neglect the patient experience and really the indication for us actually doing treatment. So this study really kind of asked the question, do improvements in these traditional metrics lead to improvements in functional status and life satisfaction? And when we think about answering that, kind of the key takeaways are that patients with intermittent claudication who had revascularization had an increase in their ABI compared to medical patients, but there was still no difference in their self-reported functional status or satisfaction. So ABI improvement really doesn't correspond to improvement in self-reported functional status. So I think it's safe to say that that's probably not true, and that our kind of measures that we're currently using are still not capturing the patient experience and really the indications for why we're doing this in the first place. Moreover, the non-operative patients were more likely to have improvement in their satisfaction compared to revascularization patients. And that really highlights the benefits of conservatively managing these patients. So how do these results compare with those two trials? So the results are definitely more aligned with the MIMIC trial. The authors kind of postulate that there might be closer overlap in the PROMIS PF questionnaire and the SF26 questionnaire. That's the questionnaire they used in the MIMIC trial. And then also they have a longer duration of follow-up in the MIMIC trial than the CLEVER trial. And obviously they've got really long, nice long follow-up in this study as well. So that might be kind of a reason for those to be more aligned. The PAQ, which was used in the CLEVER trial that we talked about a little earlier, does have greater sensitivity than the SF36, which is used in the MIMIC trial to detect clinical changes. And using non-PAD specific questionnaires like the PROMIS, which is not PAD specific, for evaluating the health status in patients in PAD, it probably makes more sense, because if you're actually limited, these patients aren't limited solely because of their PAD alone. They have a lot of comorbidities, and there's a lot of kind of pieces of the puzzle that might be contributing to why they feel physically limited. So using a PAD specific questionnaire may actually not be the best way to really capture the full picture for those patients. So some limitations. Obviously, this is a retrospective observational study from a single center, so that can sometimes limit generalizability as well. Patients with CLTI were excluded, so potentially this is a healthier patient population than what we're seeing kind of in clinic and managing. This is certainly a risk of non-response bias. The PRO completion rate for their patients was 13 to 57%, which is quite good. And they do mention that it did not differ between the two arms, so hopefully that limits the bias effect on the results. And then, we don't have great data on really exactly what medical treatment they were on, what their adherence to that was, or whether they were really truly doing supervised exercise therapy. It was really a recommendation for that, not mandatory to be included in this study. So in conclusion, long-term patient-reported outcomes assessing functional status were similar with patients who had intermittent claudication regardless of the treatment strategy that was used. And I think the results of this paper really support using a more conservative approach when we're treating patients with intermittent claudication, and that's certainly consistent with our clinical practice guidelines from the SVS rather, and our appropriate use criteria as well. So with that, thank you for the opportunity. I look forward to hearing the discussion and all the questions.
Thank you. This was an absolutely excellent study and paper, and a great presentation. I think this was one of the most enjoyable studies for me to read over the last couple months. I have a couple questions. There are a couple questions from the chat. One, and I'm not sure if you'll be able to answer that. What I'm dealing in my practice is I can counsel my patients about conservative management, but there are a couple institutions around me. So if I don't do the procedure, the patient may end up going to another institution. And because of our EMRs are not talking to each other, I may not know about it unless the patient self-reports. I am curious how that was managed in this paper, and whether those people were identified, excluded from the studies, or is that just not a thing around this institution? I think Dr. Brook is on the chat. Maybe he will be able to help with the answer to this.
Yeah, thank you for the excellent overview of our study and kind of putting everything in context, and also for that. That's an excellent question. Where we practice in Salt Lake City, there's really only one other major health system that we might share patients Intermountain Healthcare, but they have their own health plan, and so honestly, we probably practice in a different environment than a lot of other people on this call right now, because there's not as much competition. And if people come to us because they value, the quality of care that we provide, and generally people aren't going to go to a different health system in our region or our valley if we give them, recommendations based on, interpretation of the evidence and how we are very fairly conservative in our management of claudication. So, I mean, it's always nice when you do a study that really reinforces and provides evidence to support your biases, because we've always had a very conservative approach to the management of claudication, and really reserving interventions for patients who have failed, non-conservative therapy. But how we're using this information now is to let our patients know that, listen, we understand, like, you're not getting better. You have maybe a job that you're at risk of losing, but we also have to provide some feedback that we've collected data, and despite undergoing a revascularization procedure, you might not necessarily gain the same level of physical function improvement that you think you might achieve. So it's just providing like another layer of, I think, information that allows patients to have reasonable expectations, because I think that's what we all deal with. Every patient that comes to our clinic thinks that we can just do this quick, simple procedure and, magically their walking is going to improve back to where when they were in their early 20s with, before smoking or whatnot. But we all know that that's just not the case. And I think this evidence, this data that we have now helps to provide some more reasonable expectations, even under best case scenarios that patients might not necessarily benefit to the degree that they hope.
Thank you. Dr. Forbes was asking, what is your method of trying to minimize the surgeon's bias within your questionnaire? Who is the medical staff that's involved, maybe I should say, in helping the patient with the questionnaire? Do they just fill it out by themselves without, because I know that I can convince my patients to a lot of things if I talk to them. So.
Well,
That's a great. Oh, sorry, Ben,
go ahead, Taryn. Taryn should be the one to answer these questions.
I think this is a really great question, and every place does it a little differently. We actually had a shift between where we were collecting it in clinic waiting rooms prior to COVID on an iPad, where when they checked in, they were handed the questionnaire on an iPad to fill out. And then COVID changed everything and we could no longer use the iPad. So we integrated a text/email system. So all the patients 7 days before their appointment are texted and emailed our patient reported outcome measures. And it is a voluntary completion. So our completion rates, during COVID and since COVID have gone down a little bit. We are speculating that if you get the text or the email at a inconvenient time, that you may not sit down right then and take the 5 minutes it would take to complete them. So I think that that's a really excellent point. But in terms of minimizing bias when studying PROMs using really validated instruments, there's some really good patient reported outcome measures specific for PAD. And then we use a more general physical function measure. So it just depends on what you're looking for, but using a really validated measure, I think is a really good way to minimize bias.
Thank you, Taryn. Actually, the last question I had was for you, specifically the amount of stuff and effort it took to gather, because this is a huge amount of data, really, and impressive, really impressive. And although we're talking about the huge variety in the response to your, questionnaires, still going up to 57%, this is something that most of us can just dream about. So how did you do it?
With a lot of help. So the University of Utah in an entire system-wide integration of patient-reported outcomes, and they did use the PROMIS patient-reported outcome measures, which are developed by the NIH, are now integrated system-wide or institutionally for all of us from December 2015 onward. So we are really fortunate. It was a multi-million-dollar integration within the whole healthcare system. So I did not personally collect all this data, but I appreciate the confidence. However, we are actually in the process of creating a application for any institution, any vascular surgery division to free open code integrate collecting patient-reported outcomes through a application. And so we would be really excited for people interested in collecting PROMs at their institution for any vascular disease process to work with us after our pilot is completed on the next steps.
Wow, well, that sounds really exciting. Thank you. I'm always interested in something that brings up the CLEVER trial. It's one of my favorite trials. I've always wanted to redo it later in life, since Alan's no longer with us. But thanks everybody for joining us in August. We'll see you in September 11th at 6 p.m. We'll also be sending this recording to the website for those that weren't able to be here today. And then look for emails and updates in SVS Connect for the September version. Thank you and have a great day.
Mm-hmm.